Hello, can you hear me well, class? Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good evening. Greetings from Indonesia. Welcome, and we are currently at the 6th session of the International Short Course 2022 Collaboration Therapy on Musculoskeletal and Neurological Disorder, hosted by Faculty of Health Science, University of Muhammadiyah Malang. First thing first, the International Short Course Committee would like to apologize to the participant as well as to our speaker, Dr. Owen, because we have technical problems, that we have to change the Zoom link twice. But now everyone has joined the class already, and we are ready for the class. Okay, and so before that, I remind you, the participant, that this session will be recorded, and as we already know the rules, we turn on your camera and turn off your mic, and the Q&A session will be after the presentation, after the lecture. As we can see that our speaker is already joined us in the meeting room today. Hello, Mr. Owen. Hello.
Hello.
Hi.
Hi.
Hi, how are you?
I'm all right. How are you?
Good here. I apologize that we have a little bit technical meeting before. Sorry, technical problems before.
No problem at all.
Okay, and so participant, I would like to introduce you all to our sixth speaker, Mr. Owen NKOKA, PhD. Mr. Owen is an epidemiologist from Institute of Health and Wellbeing, University of Glasgow, United Kingdom. And today, Mr. Owen will be sharing with us about his expertise about rehabilitation and multimorbidity of long-term physical and mental health condition. Please give Mr. Owen all your attention. Without further ado, Mr. Owen, time is yours.
Thank you so much. I think for starters, I'll switch on my video so that people can see me, and then I'll switch off my video. Yep. Because we might have internet problems. Okay. So yeah, can you see me?
Yeah, very well.
Great.
Hi.
Hi. So yeah, I've already been introduced. My name is Owen NKOKA. I work with the University of Glasgow and the Institute of Health and Wellbeing. My research interest at the moment is in twofold. Number one, I conduct research on health and demographic surveillance systems, and I also conduct research on long-term conditions. So we'll talk more about my interests later on within the talk, but today I'll be presenting on rehabilitation and multimorbidity of long-term physical and mental health conditions. So I'm going to switch off my camera. I'm sure all of you can hear me. As you can see on the title page, I've also shown my Twitter handle. So for those of you that are on Twitter, feel free to follow me. I'll follow back, and we can share our work on Twitter. And that's also my email address. If you'd like to get in touch after this talk, feel free to do so. I'm happy to create networks and collaborations. When I start talking about the work that we are doing in Africa and also other parts of the world, I think you'll be interested maybe that later on we can work together. And that's my profile under University of Glasgow. If you want to check more of the work that I'm doing and what I've done before, you can follow that link. But our today's talk is on rehabilitation and multimorbidity of long-term physical and mental health conditions. Okay, excuse me. Right. So our talk this, I think, evening, I don't know, morning, afternoon somewhere, we will talk about, I think, a lot of things, but mainly we are focusing on rehabilitation and multimorbidity. And we want to see what multimorbidity is and rehabilitation is. And then I'll focus also on my current work, but we'll take more time in the first two points on multimorbidity and rehabilitation, and the steps and components of rehabilitation of multimorbidity or physical and mental health conditions. If I'm not mistaken, I think I have a maximum of 1 hour, but my presentation should be 30 minutes. I don't know, correct me if I'm wrong. So I'll try as much as possible to be within time because my presentation is a bit long. The problem with these online interactions is that there's no deep interaction between the class among the members, because I like asking questions, but maybe it's not going to be possible in this session. So I'll keep on going. Multimorbidity. I'm sure a lot of us have heard about what multimorbidity is. There have been a lot of studies that have looked at multimorbidity. The challenge is that it depends on the definition in different parts. But overall, multimorbidity is defined as having two or more physical mental health conditions. In the studies that have been conducted on multimorbidity, you see that there are limited conditions that are put or are considered when people are looking at multimorbidity. However, regardless of those differences, I think this is an important topic to discuss, and I'll explain why. So there are these terms that we need to take into account. So there's long-term conditions, there's non-communicable disease, and there's also a term of chronic diseases. So I think all of us have come across those ones. In my line of work, we don't prefer to name these conditions and non-communicable diseases, because that actually limits us to conditions like diabetes, hypertension. But also, as you may be aware, we do have conditions like HIV, which is a long-term condition, and it has also implications on some of the non-communicable diseases. So in order to encompass most of these conditions, we like to term these conditions as long-term conditions. So long-term conditions, these are conditions that will not easily go away. In simple terms, that's what we are going to say. And they include diseases like diabetes, hypertension, HIV, stroke, heart disease, etc. And multimorbidity, multimorbidity just means that having many of these diseases, of these conditions, okay? So if we're talking about multimorbidity, we are talking about someone who has two or more conditions. And this is actually an area of interest in so many parts of the world, because most of the healthcare systems around the world have focused on disease-specific service delivery. So if you go to a hospital, you might find a specialist on diabetes, you might find a specialist on heart disease. And these streams of conditions have from way back been taken care of. But now, because of the coming in of conditions like HIV and AIDS, people are now having two or more conditions. If someone has two conditions, that's called comorbidity. But if you have two or more, so that would be 2, 3, 4, etc., it will be called multimorbidity. This issue about multimorbidity is also important, mostly in low and middle income countries, for the purposes of looking at their healthcare systems. So the healthcare systems in these countries, in these low and middle income countries, are usually fragile. They are constrained because one, maybe lack of resources, lack of appropriate expertise, etc. So having that constraint, it's important that we understand and characterize multimorbidity in this area, in these countries, in these regions, because it will help us to understand how best all these conditions might be managed. Also, understanding helps to come up with the appropriate and sustainable healthcare, and also to design service delivery models that take into account people living with 2 or more conditions, people that are multimorbid. So thus far, we've looked at different terminologies in terms of multimorbidity, and then NCDs, non-communicable diseases, chronic conditions, and long-term conditions, and how these are important to healthcare systems, especially in low and middle income countries. So if we are talking about multimorbidity, we actually know that there are a lot of factors that come into play. So we can actually look at the risk factors. There are traditional risk factors that have been looked at extensively in literature that actually are associated with the multimorbidity or long-term conditions, and also the impact of long-term conditions on the healthcare, on the patient. So the conceptual framework that you can see, you see that there is a linkage among different, factors. So you see that I've put in socio-demographic factors. Okay, there are socio-demographic factors, there are lifestyle factors, genetic factors. All these have been studied already to be risk factors for long-term physical and mental health conditions. However, let's also put into consideration that these risk factors can be specific to specific conditions, but also because they are specific to different conditions, that might also influence in terms of multimorbidity. Now, when we look at now the impact of multimorbidity, we look at impact on patients. These might include poor quality of life, increased hospitalizations, and premature death. For quality of life, I'll just give an example. In terms of people that have a disability, you see that their functional ability in day-to-day life decreases. So if you just go on internet, look up, you see that maybe the productivity of people with disability, the literature will tell you that quality of life goes down. They cannot function properly as normal people. They have challenges. In terms of hospitalization, I've spoken of how the healthcare systems in low and middle income countries is constrained. And now the increase in hospitalizations mean that it will put pressure on this already constrained healthcare system. So we can also look at maybe space in hospitals. How does the increase in hospitalization affect space in hospitals? How does it affect or put pressure on the health service in terms of expertise needed to take care of these patients? So multimorbidity really has an impact on a number of issues. In terms of low patient activation, if you're having different conditions, maybe 2 or more, it is very difficult for you to know what the problem is. So in terms of awareness on the part of the patients or on the part of the healthcare service delivery system to identify individuals and put them on the right treatment is also a challenge, and it has an impact. In terms of the health system, we can see that, it will come up with increase in demand for care, and also increasing demand for different care models. So that's in general how multimorbidity affects different parts of the healthcare system. Okay. Excuse me. Now, I want us now to focus on rehabilitation of long-term conditions. And rehabilitation of long-term conditions, especially multimorbidity, can just be defined as the delivery of care across clinical streams, targeting people with 2 or more diagnosed long-term conditions. What is the main aim? Number one, the aim of rehabilitation for multimorbidity is to restore, and 2, to maintain an optimal level of one's functional ability. So I talked about how, you know, people with multimorbidity will have decreased quality of life and also daily functioning. So now that's where rehabilitation comes in. We want to restore and we want to maintain, because these are people that have, you know, already have been attacked by different conditions, and obviously their functioning ability has decreased. But how do we restore to the best of our ability? 1, and 2, how do we maintain that to ensure that they operate at optimal levels in terms of their functional ability? So you look at, this is a wide field that we can spend, you know, the whole week, the whole month maybe talking about. But basically, the main aim is to restore and maintain. And in terms of access to rehabilitation for services for multimorbidity individuals, it's limited. Like I've said before, you see that most of the healthcare systems have focused on disease-specific service delivery models. I will talk about the approaches later, but because of that, multimorbid individuals have really faced a number of challenges in terms of accessing care models and actually rehabilitation. And I think this is also more prominent or more paramount in areas where, you know, access to services is limited, just like the rural areas, etc. So if you go to different countries, you see that people living with multimorbidity, especially those that are away from or have difficulties in accessing healthcare, will have problems in terms of finding out on the rehabilitation services that are available. And in some countries, you also see that these rehabilitation programs are not available at all. So this presents a challenge. So what are the benefits of rehabilitation of multimorbidity? Like I've said, there's in the conceptual framework that we looked at of multimorbidity, one of the impacts on patient is mortality. So if we do rehabilitation, we might, to some extent, reduce maybe morbidity and mortality, improve their functional capacity, and also reduce admissions to hospitals and subsequent length of stay in hospitals. If we were in an interactive class, I would have probably have several questions here, because this is an important area to look at. I spoke about increased admissions in hospitals as one of the impacts of multimorbidity or physical and mental health conditions. And also I want to stress, when I'll be talking about the work that I'm doing currently, I want to stress why it is also important to include mental health conditions in all this talk about multimorbidity. But you see that improved psychosocial well-being and reduced stress is also one of the benefits of rehabilitation. So maybe a lot of people, when we talk about rehabilitation, they maybe think about physiotherapy. They only think about, you know, all that physical work that is involved in, you know, rehabilitating people that have different injuries. But it goes beyond that. It's not only about physical rehabilitation, but even rehabilitation to improve mental health well-being. So there are different approaches in terms of, we can talk about several approaches or in terms of service delivery models for rehabilitation, but all of them can be summed up in twofold. So number one, these are disease-specific rehabilitation. And then the second one is chronic condition rehabilitation. And for the chronic condition rehabilitation, this is the one that we're talking about today, about multimorbidity, because it actually focuses on individuals that have 2 or more conditions, but I'll come to that later. Let's look at disease-specific rehabilitation. So for disease-specific rehabilitation, this one looks at services that are provided within a clinical stream. So when I talk about clinical stream, I know there are medical doctors around, there are nurses, etc. In a medical setup, we have different streams. For instance, you have a heart section, you have different sections that look at specific, and they are specialists in those sections. So when we are looking at disease-specific rehabilitation, we are looking at in the conditions where an individual will be provided help within one stream, within a clinical stream, not across streams. So that's the difference between rehabilitation for multimorbidity and rehabilitation for disease-specific conditions. So I wanted to give an example here about a disease-specific rehabilitation. For instance, we have individuals, for maybe let's just look at an individual who is suffering from less breathing problems in short. So this person is experiencing severe shortness of breath and requires long-term oxygen therapy, maybe, for instance, maybe 10 hours per day. So this person obviously will have to go through a pulmonary rehabilitation program. And this is specific for the breathing problems that this person has. I hope the class can understand what we mean. So we've mentioned about breathing problems, and this person will have to go through pulmonary rehabilitation program. And it can be at a hospital or it can be home-based. It doesn't really matter in terms of the setting, but the program that he can be on is one program, one clinical stream. When we're talking about the chronic condition rehabilitation or for multimorbidity, we are looking at people that have a range of symptoms for chronic conditions or for long-term conditions. And now, most of the times when we are looking at rehabilitation for multimorbidity or physical and long-term conditions, is that we don't really have the individual will not really present with specific symptoms. So there will be non-specific symptoms. There will be a number of comorbidities, and then that will entail us or will guide us to say this person might not really need to be under one clinical stream. So for multimorbidity rehabilitation, we are looking at services provided across clinical streams. So a person will present with a range of long-term conditions. I'll give an example on this one. Let's look at an individual who possibly has maybe heart disease, and at the same time they are presenting with, for instance, osteoarthritis in the knees. So what does that mean? That means that this person will have to be put in a program that takes into account the heart condition and also the problem of arthritis. That's what rehabilitation for multimorbidity is. So we have these two approaches in terms of service delivery models for rehabilitation. And the second one is the one that is specific for multimorbidity. The other one will be disease specific. So we just want to look at a number of components in terms of when we're looking at rehabilitation of multimorbidity. Okay, so the figure that you are seeing, this actually summarizes the whole rehabilitation for multimorbidity program. And it's quite intensive because it has a number of components, I think about 8 components that we can look at. And I will just quickly go through these components because they are important for us to to look at. But if you see on the figure, you see that the first part, the blue part at the end, where you see an individual in a human being in green, it's called referral to service. So they're outside the box. And then we want to link this person to service, right? So that's the entry point. And in terms of referral, there are a number of things that we need to be taken into account. Number one is that we need to, this person has to be referred by a qualified practitioner, because we just don't want everyone to come into the program, but we need a qualified practitioner to be the ones that are referring. So these could be primary cares, maybe practicing nurses, care coordinators, general practitioners, etc. And we need also to collect information of this person. And that information will include the person, next of kin, etc. And also some of the service providers that this person has been to. And then we put them into the program. Now, the most important part after referral to the service will be screening. So this is now component number one of rehabilitation of multimorbidity. If you look at screening, what screening wants to do is to determine the eligibility for rehabilitation for multimorbidity of this individual. So in this screening process, there's a need for medical clearance so that this person can take part in this program. So in terms of screening, we want to determine the person's ability to improve their physical, mental, or even social skills by participating in one or more components of the rehabilitation. So you see that there are so many components, but at the screening level, what we are trying to do is to determine if this person, if they take part into this program, are they going to improve? So if they pass that screening exercise, and then they are put into the program. Okay, so we want to understand the needs and access requirements for this person to maximize engagement with the service prior to comprehensive assessment. So there are a number of screening tools that are there. I think when I'm talking about the work that we are doing, I'm going to show you the data that I have that is mainly on screening, and then we can put people into the rehabilitation program. And then the next step that we can look at in this diagram is the development of rehabilitation plan. So you see that on top of this figure, there is that line that reads development of rehabilitation plan. And why is it cutting across pretty much the whole of the box? It's because this exercise starts at screening stage. So we are screening an individual whether they should be part of the program, but we want to start, because once we confirm that this person can be part of the rehabilitation program for morbidity, then we need to start planning for their rehabilitation. Okay, so the development of the rehabilitation plan may begin during the screening stage after confirming that rehabilitation for multimorbidity is likely to be of benefit to this individual, and it should continue throughout assessment and monitoring and review stages. So in all the stages that you can see, initial assessment, even at the intervention stage, we should continue planning, because we can't just say we've planned at the beginning and then we stop there, but it has to be a continuous process to plan. So in terms of planning, we need to actually understand the medical history of this individual. We need to understand what are the current levels in terms of functional ability. We need also to see what tools can be used to assess results as they're in the program. So there's a lot of planning that goes into this section, because we need to make sure that we are on the right stage. And then between there, you see that there's disease-specific rehabilitation and chronic condition rehabilitation. The chronic condition rehabilitation, in your mind, don't think of one condition. These are two or more conditions, because chronic condition rehabilitation focuses on individuals that have two or more physical or mental health conditions. So Once we screen them and they are in the program, we are developing the rehabilitation plan. The next step is assessment. Why are we interested to do assessments? Assessments are important, especially at the start, and then progress, and also at exit assessments. They are important that this should be done. It's also important that when we are doing this as practitioners, we need to keep in mind that we need to obtain consent. So what I'm presenting, this is something that was discussed I'll share you the references at the end so that we are on the same page and you know where all this is coming from. So we need to get consent from our clients to make sure that they are assessed in this program. The reason why we want to do assessments is, one, to develop an understanding of the person in general, and two, to increase the knowledge of that person from a physical and psychosocial perspective, because that is important in terms of our also planning as well on the interventions that this person might need. Because how do we come up with intervention options if we don't, if we haven't assessed our clients? And also we need to assess the functional exercise capacity and design and prescribe an individualized program for these individuals to be able to access their required programs. Also, we want to understand the level of health literacy, because health literacy is also an important tool, and level of activation and capacity to participate in self-management. So you see that after initial assessment, we want to link individuals to different intervention options. So after completing the assessment and discussing the results, we want to come up with, now we'll go back to the rehabilitation plan. And so in the rehabilitation plan, what we are going to do, we are going to complete, for instance, current functional levels, and then what will be the assessment tools, and then what are the key issues that have been identified during the assessment. And then another important thing that we do is to put in goals. So what are the goals that we want to achieve during this rehabilitation? And then let's look at the intervention options, because that's also another important aspect of component of rehabilitation. So in terms of intervention options, we have several intervention options, but the main approaches in terms of rehabilitation, intervention options is self-management support and disease management. And these might include a lot of things, and I'll talk about that briefly. I'm trying to catch up with my time. So if I'm very fast, I'm going to share this presentation, and then you can also be able to read through. So let's look at self-management. So self-management will include things like smoking cessation, nutrition, etc. If we go back to the conceptual framework that I showed earlier, you see that smoking is one of the risk factors for multimorbidity, because that's a risk factor for hypertension, that's a risk factor for a number of conditions, and therefore it's a risk factor for multimorbidity. Nutrition as well, and I talked about lifestyle factors. So these are lifestyle factors. In terms of psychosocial and psychological and social support, these are also important because we have to look at a number of issues here. I want us to focus on especially behavior change. So before I go to psychological and social support, I want to focus on behavior change. Some of you may have come from different backgrounds, but I think we have come across what we call the trans-theoretical theoretical model. This one is specialized on understanding how people can identify in terms of behavior change. So all those stages that are within that trans-theoretical model need to be applied. For instance, contemplation, preparation, action, and maintenance. So these are the stages that can be considered when looking at behavior change, because most of the things that we're looking at under self-management support is behavior change, because most of the risk factors, and these are traditional risk factors for long-term conditions, lifestyle factors. So when you're looking at psychological and social support now, these are factors that may impact on ability to self-manage or benefit from interventions, and may be identified following an assessment. And in these situations, the inclusion of psychological management approaches is critical and often poorly implemented in people with long-term conditions. And therefore, it's important that we look at this as an isolated intervention plan. We need also to identify that people need to be encouraged in terms of how they engage in activities that have been recommended. So just to go further, I think I will provide the resources for this. This can take us almost a day to explain about, you know, the components of rehabilitation plan. But at the end, you see that there's maintenance. So it's important that people and carers should be encouraged to support and continue practicing. So people can be discharged after the program, but there's need that, you know, there's continuous follow-up. We need to maintain, and also we can also link them to other services. So basically, these are the components of rehabilitation program for multimorbidity. I'm going now to look at what are the enablers of multimorbidity rehabilitation. We are going to an end, so don't worry about time, and then I can give time to respond to our questions. So there are a number of enablers. You know, I'll just go quickly because we have provision of individualized or person-centered services. This will just include, you know, having the capacity to have a care that is based on collaborative and respectful partners between the service provider and the participant. And then we can also look at flexible service delivery models. And these models actually look at targeting people with different conditions. And when we target them, we need to support the needs of individuals with different comorbidities and have services that may strengthen the linkage with specialist rehabilitation services. So like I've said, there's a non-specific and then disease-specific, and then there's a chronic condition one. So we need to take into account all that. Innovative staffing models. I'm sure most of us have come to look at, I've come to terms with telehealth. So I can be in the UK and people can be in Indonesia, or others can be in Vietnam, but we can, at the end of the day, have a telehealth system where, you know, we can pretty much link up and help each other on administering some of the services that are needed. So we talk about information and communication technology. This actually just looks at the increase of the use of new and innovative technology and web-based devices in transforming health management. And then there's effective communication, knowledge sharing, and partnerships. We need to create partnerships so that we share knowledge and, you know, we communicate amongst ourselves to ensure we improve service delivery. Settings of care. This actually looks at access to equitable access that requires flexible service delivery arrangements. Definitely, this actually helps to enable services to better suit the needs and requirements of individuals. And then open access and referrals. So for this one, we are just looking at how referral pathways can be developed in order to help link individuals with specific comorbidities or multimorbidities. Okay, so in order to finish, what work am I doing at the moment? Because we can talk about, this is more theory. I've talked about, you know, components, I've talked about the importance, the conceptual frameworks, you know, all that. But what what is it that we can do to apply this in our communities in areas where we are working? So as of now, what we are doing is to create a longitudinal cohort. So we are registering people to be part of a cohort. And in this part of the cohort, what we are doing is to follow up people over time. So under this large cohort, we have another large cross-section study that we are looking at physical and mental health conditions. And the whole purpose of doing that is we want to identify clusters or specific conditions that are common. And then we can identify service delivery models that are suitable for those clusters to improve and then recommend those service delivery models. So in a nutshell, my current work focuses on these figures. You can see we have a cross-sectional study on long-term conditions. So we are doing this study in Malawi. Malawi is in Africa, for those that don't know. And we are trying to, why Malawi? Malawi is because it's one of the poorest countries in the world. Again, we talked about the healthcare systems. So the healthcare system in Malawi is very constrained. So it's important that we look at Malawi in that sense of multimorbidity. And Malawi also focused a lot on infectious disease for a long time. So a lot of funding was going to infectious diseases. And now a lot of people have started, facing problems with long-term conditions. HIV is prevalent, and we also have non-communicable diseases that are coming in. So it's important that we look at that. So what I will be sharing here is the preliminary data. This is the map of Malawi, where our work is focusing. We have the rural side and urban side. So we do have the one that you see there is the health and demographic surveillance system. We are following about 110,000 people. And then we have nested within that the long-term conditions survey. And this includes adults and adolescents, those aged 15 years and above. And these are going to be about 50,000. And then we are collecting information on a number of issues. So this is the data we started actually last year to do that. We are collaborating with the other institutions in Malawi where we are doing this study. But definitely, we are just collecting, we have interviewer-led questionnaires, physical measurements, and blood samples where we're doing a lot of measures for long-term conditions. As you can see from the picture, that's in Malawi, the picture that you see there. These are interviewers taking measures from our participants. I don't know if I still have time, but I just wanted to finalize on the preliminary results of this data. It's quite interesting, and I want to show you why I'm sharing this kind of work. So some of the measures that we are looking at are heart disease, stroke, chronic pain, HIV, asthma, diabetes, hypertension, disability. We're also looking at depression and anxiety. And so we are defining, because I mean, in any work you can choose to define. So we are defining how much morbidity someone having two of these conditions that I've shown. And then we have different variables that we're looking at. And in this preliminary result, I'll just show you the age standardized prevalence estimates. So these are the standardized prevalence estimates. And as you can see, the highest that is being reported is hypertension. And I think around 15.2% prevalence of hypertension. The lowest would be stroke, but definitely it's because we do have, in Malawi, there's poor quality of health services. So a lot of people probably with conditions like stroke who have died will not survive. That's why maybe the prevalence will be like that. So we'll see that when we compare males and females, there's not much difference. So for instance, if you look at hypertension, not much difference, because if you look at the confidence intervals, they're overlapping. So it's pretty much common. So far, the data that we are collecting is revealing that, the prevalence of this condition is there, but not much difference between males and females. So this is age standardized prevalence of the physical and mental health conditions that we're looking at. And this one will show you that I think those aged 55 and above will have at least 2 or more disorders. So multimorbidity is really a problem in Malawi. But the problem is the healthcare system, if you look at the healthcare system, probably is not ready to take into considerations people with multimorbidity. For those aged 15 and 25, you see that there's a percentage that has multimorbidity as well. And interestingly, you see that as age increase, the number of people with 2 or more or with multimorbidity increases. So you see that between males and females, not much difference, but the difference will be observed around middle-aged women having a higher prevalence of multimorbidity as compared to middle-aged men, those aged between 45 to 55. So there are a number of things that we are doing to look at multimorbidity of physical and mental health conditions. So I'll skip some of these results because they are not relevant. But why am I sharing this? We have looked at for multimorbidity only in Malawi. If we look at the data that we have, multimorbidity starting as early as between 15 years of age, 20 or 24 years of age. So what it means is that in the future, let's say 10, 15 years from now, we have a population that is living with multiple conditions, but the healthcare system is not ready to take part in terms of managing these conditions. And in the results that we also have, we see that the physical mental health multimorbidity is also linked to mental health disorders. I haven't shown those results, but they are there because of time. I'm just trying to skip. So what we are doing is that with the data that we have, and we just want to understand what are the clusters, what conditions. So we have so many conditions. The conditions that I've shown there, they are limited. We have so many conditions. We want to see which conditions are the most common and at what ages. And then how best can we recommend in the healthcare setup, probably from primary, secondary, and tertiary healthcare systems, to see how best these people can be helped. Because if they go, maybe it's only the infectious disease specialists that they're going to get. But if someone has diabetes, are they able to get help? If someone has hypertension, if someone has stroke, are they able to be enrolled in rehabilitation programs? So what we are trying to do is to create that database. And the reason why I actually put my contact there is because we now in Malawi, we have a database. If you want to collaborate, you're welcome to do that. That database, you can also come in with your studies that we can look at different things that are related to multimorbidity or physical and mental health conditions. And so my talk mainly focused on the study that was done, the report from and also some of the authors that you can see there that have written extensively on multimorbidity of chronic conditions. But in this one, I've adapted it to physical and mental health conditions. Why physical and mental health conditions? You see that on the adjusted prevalence rates, mental health conditions are becoming one of the important conditions around the world, and that they need to be considered. And the problem with the mental health conditions in most of the low and middle income countries, these have been overlooked for a long time. And now it's the time that they should be taken into consideration. People should be linked to care and rehabilitation programs if they have problems with long-term physical and mental health conditions. So my talk ends here. I'm sorry, I've taken more than, I think, 45 minutes or 40 minutes. I'm now open to get some questions on the talk. Thank you.
Okay, thank you very much. No problem, that's over time. Okay, so and now the Q&A session, please. The participant who want to ask Dr. Owen, please put on your mic. And it's already a question in the chat box, Dr. Owen.
Sorry, come again?
Yeah, it's already one question in the chat box.
Okay, let me check it out.
Yeah. Yep. The question is, hi, Dr. Owen, can you give a few examples of non-specific symptoms of a disease for participants who always come to rehabilitation? And does multiple sclerosis also can be divided in non-chronic and chronic patients? That's the question.
Okay, all right, I've seen the question. So I think there are two questions there, whether I should actually give examples of non-specific symptoms of a disease for patients who always come to rehabilitation. And the second one is, does multiple sclerosis also can be divided into non-chronic or chronic patient? Thank you so much for that question. I think those are excellent questions. I think I already gave an example on this one. I'll just give an example on an individual probably with the maybe a disability, because I'm looking at also disability at the moment, or let's say chronic pain. So let's look at chronic pain of the maybe of the head or of the leg, because we are looking at different parts in the human body. So that person who have a specific symptom. But if you look at individuals that have, let's say, hypertension or have anxiety or depressive symptoms, you will not really differentiate them, because this person might be having depressive symptoms, not anxiety per se, but these are closely linked. So the reason why we want to do some clusters of physical and mental health conditions is because when we analyze data of such people, it shows a different pattern. So you have individuals that are maybe have maybe hypertension and diabetes, they will be in the same group. And then individuals with anxiety and depressive symptoms are in the same group. So we can identify them like that, but we cannot be sure that if this person, in the first place, if this person is depressed or is this person having anxiety disorders. So it's important to do that. So there are so many examples that I can give, but most of these, conditions, if a person has two or more, there will be closely linked conditions. But in order to identify them, that's why we need to link them up to the chronic conditions rehabilitation program, because there we can do further assessments. The second question is, does multiple sclerosis, is multiple sclerosis also divided into non-chronic or chronic patients? I haven't had really an experience with this, so I will not be able to respond to that. But I will say, in terms of cirrhosis in general, we can say that yes, they can be categorized into, I think, chronic conditions. But I think for this population that I'm working on, this is something that we haven't observed so far, and we are not measuring that. Probably that's why I cannot give a right response to this one. Thank you.
Okay, so that was the answer. Okay, is there any other participant who want to ask? Please turn on your mic to talk directly to Dr. Owen. As we wait for other participants to ask Dr. Owen, actually, I have a curiosity. I would like to ask, is there any report about the most condition that cause multimorbidity in elderly?
Okay, yeah, that's a good question. So in the elderly, I think most of the conditions that have been reported, honestly, are to be you see in the data that I've just shown, there's disability, there's chronic pain. The challenge is that most populations, maybe these are not collected. This is information that is not collected. Most of the information that is collected will be diabetes, hypertension, maybe stroke, etc. So it won't give us a true reflection. But for those conditions that have been reported, I think hypertension, diabetes, these are the most common conditions that will be reported, and this is the most common cluster that has been there. But we shouldn't rule out issues to do with also heart disease, Depression and surprisingly, depression and anxiety will be reported mostly in the middle-aged group. So for the elderly, we should look at maybe diabetes and hypertension.
Okay, so the
But
diabetes
I'm sure that with the if we have the capacity to measure to have a lot of measures in populations, some of the things that we can observe, and with the data that currently we have, we'll see that chronic pain and disability are also one of the things that are being observed within these populations.
Okay, thank you very much. Socrates and diabetes for the elderly. Okay, so is there any other participant will ask? You can list on your mic to talk directly to Owen. I think it's all Dr. Owen. Is there a participant? No. Okay, Dr. Owen, that's all for the Q&A session. Thank you very much. Thank you very much, Dr. Owen, for the information. That was interesting. I learned about multimorbidity a lot, and I hope all participants also learned about the topic for today. And that was and part with Dr. Owen. I could thank you for all the information and the interesting for the class. Thank you very much, Dr. Owen. Before we leave Zoom meeting, I would like to ask all the participants to turn on your camera, and please, if there is we can take a picture together before we for the Zoom meeting. If you want to take a picture together, please turn on your camera. All participants, please roll and hi.
Hi.
Okay, so Miss Zak or Miss New will help us to take a picture.
Okay, on 3, 1, 2, 3. Okay, thank you.
Oh, it is one. It's very okay. Thank you very much, Dr. Owen, for the. I hope that we can visit UK, maybe University of Glasgow, or can go to Asia, so we can have this kind of class offline. Hopefully. Thank you very much, Dr. Owen. And thank you to all participants for joining, and I would like to remind you that the next class will be on Thursday, 14 June 2022, 6 p.m. Indonesian. Details will be sent to you by emails and the WhatsApp group. Thank you very much. See you all next Tuesday. Bye. Assalamualaikum warahmatullahi wabarakatuh.
Salam.